So good morning, everyone. It's now April 19, Monday. Would be nice if I had my glasses. This is now week 6 out of week 10. Grades are already been posted and are out. If you have any questions, please give me a call. And what's week 6 like? What are we doing? Well, we're doing urinary system, and that is chapter 7 in your textbook. And what is due today? I believe, yes, you have a quiz. Yes, you have the discussion. And it's not really a discussion per se. It is design a quiz. And I have a sample on how to take a case and make it into a quiz. The quiz should have, every question should have multiple choice, A, B, C, and D. And of course, because you had a midterm last week and probably had other midterms and papers and whatnot, try to get this to me by closing of business today, which is 6 p.m. if you have not done so already. And of course, quizzes, don't ignore your quizzes and your medical language laboratory for any week 5 items. My lecture, if from last week, since we didn't have a lecture, it's in announcements and it's here, week 5, pre-recorded lecture, and it's right here. And the topic from last week, week 5, was endocrinology and neurology terms. But what is this week? This week is, you know what? I'm in the wrong urinary system and renal. Let's go to Firefox, because Safari for Macs, like I've stated before, is not so friendly. Towards Moodle, and of course, definitely your medical language laboratory. So we go in medical language lab, and we're looking for chapter 7. There's the ebook. Just as a side note, overall, the results of the exam were good. Test score is a little bit lower than usual. It was in the 80s, but still, that's a pretty good average for a class. But again, right, this is medical terminology. It's a 100 level class. It's not meant to. It's meant to be more like training, and less of. It's more like an introduction, but use it because when I was grading exams for my other courses, a lot of what people got wrong on more technical questions was because they misunderstood, or they misunderstood something that could have, because due to medical terminology. And here's a classic example. I teach a Saturday clinical course, and students were at like the word hypertension, right? No. What was the question? It was tachycardia versus bradycardia. People knew the answer, but they were switching fast versus slow. So if you want tachy means fast heart rate. So the student knew the correct answer, but they misunderstood the medical term, and hence they got a what should have been an easy question wrong. And I was seeing a lot of that in anatomy and physiology too, and my clinical class on Saturday. And then I even asked the student, "Hey, what's?" It goes, they're like, "Oh, I didn't see the word normal anywhere." And well, the medical term eucardia or utensive, EU would be the prefix. EU means normal. But it goes to show that these classes yeah, you may have aced them, but you gotta try to retain as much as you can, because these are building blocks. There's a reason why you take the prerequisites before nursing. A lot of students, not a lot, but there's a handful of students who complain like, "Why do I need those prerequisites?" And then they go into nursing and they fail out. Well, it's not because you're stupid. It's not because you're lazy. Because many times you do not retain the previous information that is required for the next and subsequent class. Remember, all of these classes build up on each other. So this urinary system thing that we're about to talk about, you're going to see again, and you're going to see it several times, and hopefully, you'll master it by the time you graduate. So when you go out into the world, it's not a problem. You don't, you can communicate freely and openly without error. So who do you deal with in the department, in the urinary system? First of all, we always talk about the people in our neighborhood. So you have the Department of Urology and the Department of Nephrology. Both are subspecialists from the Department of Internal Medicine. So these people went to school for a very long time. They not only went to 4 to 5 years of internal medicine, they took a urology specialty and a nephrology specialty on top of their internal medicine. So what do urologists do? Well, they deal with urinary problems. Now, if you look at this, for those of you who haven't had anatomy physiology yet, the way you make urine is your kidneys filter the blood. Blood comes in here, and kidneys filter the blood. Then it goes down these tubes, ureters, and you got two kidneys, two ureters. Then it gets into this holding tank, the urinary bladder, and then goes out into your urethra and then goes into the toilet. Well, if there's any problem with the urethra, the bladder, or any of these ureters, then that's the job of the urologist. Now, another thing that the urologist does is also they work with the main the male reproductive disorder. So if your male patient is having reproductive issues, then they go to the urologist. If it's a female patient, the female patient goes to the gynecologist. So let me repeat that, because that's a good thing to know. So if you got a male patient and they have a reproductive issue for the organs of reproduction, they go to the urologist. If it's a female patient with a reproductive issue, they go to the gynecologist. Now, some of you are saying, well, my cousin went to went to a fertility specialist, which is a subspecialty, and both potential mommy and daddy went to see that person. Well, that person is called a urogynecologist. So it is someone who will deal with both male and female reproductive issues. But overall, urologists, they work on anything that has a urethra problem, bladder problem, or ureter problem. And those were the tubing and the items before the kidney. Now, anything after, if that problem that we just saw here goes all the way up to the kidney, then we have to call this guy or gal. If it's a kidney issue, that is the nephrologist. And nephro, that's kidney. Oops. Okay. Lovely multiple choice question right here, especially now that we're doing cases. If I have a case of or I'm doing triage for the front desk or maybe outpatient department, right? And I have a patient coming with a female patient coming solely with any reproductive issues, then I have to send them to the gynecologist. If I have a female patient that has like a UTI, urethra, or urinary tract infection in the level of the urethra, bladder, or ureter, then they go to the urologist. But if I have a female patient that has a kidney problem, they go to the nephrologist. Okay. And then that could be same said for the male, right? So urology, that's a little bit tricky, and there's a lot of like cross training in between urology and gynecology. Now we look at the anatomy. Of course, there's the kidney. That's the star. But but this chapter also talks about all the other accessory items, because the kidney is the star. That's why it has its own like person to deal with this. And by the way, it's one of the most high. It goes. There's millions of people that have kidney disease, and it's super preventable. The two things that ruin these things is hypertension and diabetes, and it kills people, kills millions of people, right? But you know my views on that. So let's talk about what combining forms. Now, we're no longer asking you what's the combining form, what's the prefix. We are now going to ask you these words in context of the case. So let's just relatively quickly go over the potential words. And then, because you guys are pros already at what's a combining form, what's a prefix, what's a suffix, we're not talking about that anymore. Now we're talking about meaning within context of someone communicating a case to you, because that is the main job of medical communication. I have to talk to you about the patient and what we're going to do for the patient and how to communicate to the patient, because our job is to take these 25-cent words and inform our patient what we are to do to them to get informed consent. So if my patient is scheduled for a cystoscopy, I tell them it's what? Well, we're going to stick a tube where? To look at your urinary bladder. Now, how would you do that? My urinary bladder is here. I stick a fiber optic tube up the urinary meatus. Meatus just means opening, and boop. And then I can visualize it in there. A vesicocele. It's a hernial protrusion of the urinary bladder. So if my urinary bladder starts, out-pocketing here or here, it's kind of painful. And that is called a cystocele. Your glomerulus is inside your kidney here. It's the main filtration part. It's microscopic, but if you're going to have a problem in there, you're going to have a filtration problem, and we have to call the Department of Nephrology. So if you had glomerulonephritis, you have an inflammation or infection of your kidney, specifically the microscopic filtering system inside your kidney, and that specific thing is called your glomerulus. And a glomerular pathology is a microscopic pathology, and it's inside here, also known as the cortex of your kidney, and that is some bad news. Meatus, right? It's not pronounced meatus, it's meatus. Since it's Latin, you pronounce all the letters. Nephro, we know it's kidney, so I could have a lump or bump. Now, if my patient has a suspected nephroma, what should I be looking for? I should be looking for the biopsy to see if it's cancer. Okay, because the tumor could be what? Just a lump or bump, or it could be a stone. Renal, pertaining to your kidney, of course, that's easy. Now your renal pelvis. The renal pelvis is this area right here. You could see that it's kind of like a funnel system. There's a funnel here called your pyramids. There's a funnel here called your minor calyx. Then you have your major calyx, and then everything ends up. If I removed all of this stuff, everything ends up here, and that's called your renal pelvis. And then all that urine gets collected, and then goes into a whole bunch of collecting ducts, and into your ureter. So if you got an inflammation or infection here in this area, right? That's a renal pelvis problem. That's and we will call that where is it? Pyelo. So I could repair that area in pyeloplasty. So if I have pyelitis, I have inflammation or infection of my renal pelvis, and that's a serious thing because it's in the star of that system there, the kidney. Uremia. Now, I mentioned that the function of this thing is to filter out the blood. Now, what happens if this doesn't do its job? It's not able to filter things anymore. If this isn't able to filter things anymore, what's going to get backed up into the blood? You're going to get nitrogenous waste, because that's the main thing we're trying to get rid of in urine. We're trying to get rid of excess nitrogens. And if you can't get rid of that, it gets backed up into the blood, and then you'll have something called uremia. And that's a sign of renal failure or potential renal failure. Another word that's similar, and that's the same exact thing, is azotemia. So if you have excess nitrogens in your blood because your kidneys aren't working very well, you could be diagnosed with uremia, and the same kind of word is azotemia. Doesn't that look like a beautiful both A and B if I have a case where my patient has impending kidney failure, right? And there's now increase of, I could ask the question on an exam, what is the increase of nitrogenous waste in your blood called? And because is it A, uremia? Is it B, azotemia? That looks like C, both A and B. Urinary, that's easy. Ureter, right? That is this tube right here. There's two of them. And that is the connection from your kidneys to your urinary bladder. You could have ureter stenosis. You could have ureteritis. Okay. There could and that's a not nephrology. That is a urology problem, and it could be you could have inflammation or infection that will make the ureter narrow or blocked up, and that's called ureterostenosis. 9 times out of 10, it's usually a stone or damage from a stone that caused ureteritis, and that now closing up the ureter. You close up the ureter, can urine go down, go to your bladder, out the urethra and into the toilet? Nope. So it's all going to back up. All that pressure is going to back up, and then you're going to get something called hydronephrosis, which we'll talk about momentarily. Urethra seal. It's a hernial protrusion of your urethra. And again, here's your urethra. It's a tube, and it's supposed to be in there. If it pops out of here or moves where it's not supposed to be, then that's called a urethra seal or a hernial protrusion. And that too will cause a significant amount of pain. We already talked about azotemia. I mentioned the word stone. If you have a stone anywhere in your kidneys, right? That's called, or anywhere in the system, or anywhere actually, it's called lithiasis. Iasis is the suffix that means abnormal condition, right? And lith means stone. Calculi is another word for stone. So if I mentioned that, upon X-ray, we found a stone in my patient's left kidney. Okay, what diagnosis would we have? A, lithiasis. B, renal calculi, and it would be what? Both A and B. So lithiasis and calculi mean the same thing. It means there's a stone, and stones are not pretty. They're sharp. They do damage, and they also promote infection. So it's never a good thing. If your kidneys aren't working, you will go through something called dialysis. Dialysis is lysis or breakdown. Dia means complete or thorough. So I'm completely or thoroughly breaking down the toxic waste in my blood, and I'm getting rid of them. That is the function of dialysis. That's the only function of dialysis, is to filter out your blood. Now, your kidney performs like 5 other major functions. So dialysis is never a good thing. You could live on 1 kidney. Heck, you could live on no kidneys, but then you'd have to go through dialysis in regular intervals, anywhere from every 48 to 72 hours after you after you have that hardcore diagnosis. And they have to do it in the kidney center because it has to be sterile, and you are going to be, well, your patient's going to be a massive target for infection. Which, by the way, you know me and my conspiracy theories. If that's the case, then why aren't people in dialysis? Why aren't HIV patients? Why aren't cancer patients getting COVID in droves? Because in theory, right, they're all immunocompromised. In theory, they're all at risk. Okay, and if that's the case, how's this? Why didn't they get the vaccine first? So remember what I stated in the first day. It goes, once you start looking at things clinically and looking at the basis of science, a whole bunch of questions are going to start popping into your head, and you're going to end up like a conspiracy theorist such as myself. Nephropathy, nephro, kidney, pathy, disease, or process of disease. So it's a process. We see it coming. Everyone who've had kidney disease, it took like 10 years. So it goes, especially hypertensive patients. All of this, especially diabetes, can be avoided. Excuse me. My mother has pre-diabetes for the last 15 years. I don't think she'll ever get it because she saw it coming and then did what? Did something about it. Now, my father, he was notice I said was. He died how many years ago? Several years ago. We all saw it coming for 2 decades, but he didn't do anything about it. And then he progressed, and then the nephropathy eventually was the thing that killed him. And ladies and gentlemen, he did not die in his sleep. He died nice and hard. And the last 12 hours of his life was extremely painful and unpleasant. Now, these are the things that you have to get to, not only yourself, but your patients. All right? If you do the work to address the pathology early, that's why the Department of Internal Medicine, we're more about prevention now. Because once you have a heart problem, once you have a kidney problem, there's not much I could do. You already have damage. But especially with children, deal with it now. Oh, my daughter was hating me yesterday, right? She had cramping, wasn't feeling good. The whole house has a cold right now. But guess what? Goes 8 a.m. rolled around, and I told her, time to go to the gym. You have a boxing lesson. She's looking at me like if I'm nuts. But what am I doing? Well, maybe I'm a little crazy, but I am interjecting a culture of, if you're well enough to walk around, if you're well enough to breathe, you're well enough to train. And why? Because my whole entire family is diabetic, it's obese, and has hypertension. And I just had an aunt die over the weekend for stuff that was highly preventable, right? So train the kids, train the children. Eat better. My children eat way better than I do. I eat garbage all day. I'm the only one who just in the family, well, in this house, that just eats Doritos and look at me. There's a problem. Now, if I remove your kidney, I have to do, if I have a nephrectomy and I replace my kidney, you have to see the kidney. It's not really, you need to look at textbooks. It looks like it's floating. It's not. There's a whole bunch of connective tissue if you recall your anatomy and physiology. And if you haven't been to anatomy and physiology, please try to get to the laboratories. I have a lot of students like, oh, it's COVID, I can't get to the labs. Okay, you'll still pass the course, you'll still do well, but you won't be able to see this. And we put it in a piggy, right? We do fetal pig dissection. You won't see how this is really connected into the human body. And that is nephropexy. Because if I don't fixate that organ well into my body, what's going to happen? I'm going to have nephrostosis, and it's going to droop down my kidney. And if it droops down my kidney, what happens to these tubes? What happens to everything else that's around here? It's going to interfere with it, and these tubes might get kinked, and then there could be stenosis, there could be infection, a whole bunch of things. And as you could see, everything has its place and order. Lithotripsy, that's what we do with a patient who has a calculi or lithiasis. We go in there and we crush it. We either crush it physically or we use sound waves. We use even fiber optic explosives. There's a whole bunch of things we do for lithotripsy. So on a case study, I could state that, oh, my patient has a diagnosis of lithiasis. Where is it? Or calculi. Which of the following is most likely that I have to schedule my patient? And lithotripsy is your most probably correct answer. Excuse me. Like I said, this got cold. And I just love when you get a cough, everyone thinks you have COVID. No. Right? Again, look at the science. I'm in my 50s. I'm in relatively good health. I have no real exposure. I haven't been to laboratories. My last laboratory was, I don't know, 6 weeks ago. So that was my last clinical contact. And it takes what? Incubation period for most viruses is 2 weeks. So what does that tell you? I just have a cold. I'm not going to die. My little one has a fever. Everyone's, oh, he's going to. How many 3-year-olds get COVID? Nobody, right? And he's in school. He's in school 4 days out of the week in a school that, and when someone gets COVID or someone even gets a cough at school, they report it. There's not a single report for his school for months. So when you look, that's what this class is trying to teach you. Look at things in context. Yes, it's true. There may be one case of a child getting COVID, but what are the odds, right? And remember, that's actually our game. What are the odds? Let's look at urea. State or condition of urine. Let's look at the different ways we could talk about the different kinds of urine. So polyuria, that's easy. Poly means many. So state or condition of excessive urination. Oh, by the way, we forgot to talk about the different words associated with urination. Urination could also mean voiding, we're going to talk about avoiding cystogram momentarily, right? And what does that mean? It means we take the test while the patient is urinating. So, of course, urination and voiding. So periodically, we're going to add stuff to the word for urination. Now, I could have anuria, which is bad news. That's a state of condition. Oh, no. Urine production. That's bad news. So when you guys become nurses, pay attention to the urine output. How many times, not only nursing staff, but doctors too, all of us are human and we make mistakes. Like someone doesn't monitor their urine production, and the next thing you know, well, it starts off like this. Oliguria. I should have started with oliguria. Is a state or condition of diminishing urine. So let's say, for example, this morning Typically, you go anywhere from a liter to 2 liters per day. So let's say my patient this morning had 50 cc's, and then at noon it's only 20, and then by 2 o'clock it's barely 10. That's oliguria. That means you see it coming. It's a stated condition of diminishing urine output. All right. And if you're monitoring right, you get it before anuria, because if you're not making any urine, one or two things are happening. One, either you have a cardiovascular problem or what's more common is you have a nephrology problem, and this is pending renal failure, and you don't want to get there. How many times I woke up in the morning, I checked urine output, there's already anuria. Then I've got to ask the staff, like, hey, anyone been paying attention to oliguria, which started at 11 p.m. last night? But I'm on the morning crew, and the evening crew is looking at me like, oh, sorry. Okay. Just imagine if we dealt with it when you see it coming. And that's the real reason why you're in the hospital, because we can see things a lot quicker and do things to you a lot quicker than we would at a clinic or your home. So let's see. Did we go over polyuria? Yeah. Polyuria, anuria, oliguria. Now, there could be things in your urine which are not good, like glucose, glycosuria, stated condition of excessive glucose. You shouldn't have sugar in your urine. You shouldn't be filtering out sugar. That means you have either a ton of sugar or your kidneys are broken. Proteinuria. That's excessive protein. You shouldn't be eating tons of protein, right? Like me, like a meatitarian. At a barbecue yesterday, all I had was an entire pork shoulder. No sides, nothing. Remember, I'm a meatitarian. Don't believe in dressing or a salad. Nope. Just a whole pork shoulder. And that's excessive protein. Means there's too much protein in my blood, or there's too much protein intake, and that's never a good thing. That's why now I'm trying to, over the last, ever since COVID started, I've been really, really trying to curb myself. But yesterday was a really nice day, and I'm the chef, so I ate a whole pork shoulder all by myself. Don't judge me. Glycosuria, proteinuria. What else? We could also have ketonuria. Ooh, that's never a good thing. Excessive ketones. That means I'm in a starvation state. Ketones are highly neurotoxic. They are not good for my brain. That's why when you go on a starvation diet, what are you going to start kicking out? You're going to start kicking out ketone bodies into your urine, and that's not a good thing. So here's some examples of when we do urinalysis, and urinalysis is U/A. That's its abbreviation. What am I doing? I am breaking down the urine into its parts. I'm looking at it physically, I'm looking at it chemically, and I'm looking at it microscopically. So I could see things coming before it goes. I start seeing manifestations in signs and symptoms of my patient. Let's look and see if any extra words come out here. Renal failure, yada, yada, yada. Oh, here's some renal stones. Little bitty stones. Now, these stones aren't perfectly round. Now, what happens if they trap here? They could block your kidneys. And then if it blocks that, it'll block up all your urine, because your urine's supposed to be down here. This is a better picture of your renal pelvis. Here's your renal pelvis right here. And all your kidney is you got a filtering system all the way out here, right? Remember we talked about the glomerulus? It's inside here, and it's part of something called your nephron, which is the functional unit of your kidney. And then once it makes urine, it goes into these funnels. Here's a funnel, here's a funnel, here's a funnel, here's a funnel, and then it all ends up here, and the stones could go here. Now, when the stones go here, any of you know anybody had kidney stones? It hurts like the dickens, pun intended, right? It is extreme amounts of pain. My wife is multi-gravid. She lived through a lot of kids. She said the pain was comparable. And for a woman to tell you the pain is comparable to childbirth, you got to sit up and pay attention to that. And what did they do for her? They did lithotripsy. They went in, they got it, they broke it up, and they removed it. She's got an extra one laying around in there that's too big to be moved. But that means maybe 10 years from now, one of these days, we got to go in there and we got to go get it if it causes any problems. Here's another thing. If the kidneys are, if the stones are a little bit smaller, we could do ESWL, which is extracorporeal shockwave lithotripsy. That looks like a 25-cent word. If you tell a layperson that's what they're going to do to you, they're going to think, what? Shockwave. Oh my God, they're going to electrocute me. This is not good. Now, it's not that they're stupid. It's just, look at this word. This is scary, right? Shock. Most people think shock, oh, it's electricity. No, it is not. So we look at it. Extracorporeal. Corpus or corpo means body. Extra means out of the body. So the sound waves are going to be coming out of the body. And it's going to form a sound shock wave. And the shock wave is going to break up trypsy, litho, the stone. So let's say my patient has this, and I would ask, out of all the management, which of the following would we do? And if I write ESWL, that is a viable answer. And you notice we monitor my patient for any other things. It's just like what we all do in surgery. For any procedure, you have to monitor your patient. Diuresis. Let's add that to the words that mean urine or urinating. So voiding means urination. Diuresis means urination. So if I give you what the patients like to call a water pill or a diuretic pertaining to urination, what's it going to make you do? It's going to make you urinate. And if you urinate a lot, and I'm talking about every 15 minutes, what will it do? It'll get the water out of your system, and your blood pressure should fall down. That's the function of a diuretic. Or if you have edema, if you have swelling all over your body, that's what we do. Hence also low sodium diet, because the way a diuretic works, it tricks your kidney into throwing out salt. And if you throw out salt, if you recall osmosis, wherever salt goes, water goes. And we'll go over that in greater detail in your anatomy and physiology class. Your adrenal gland or your suprarenal gland. Let's look at that. See these little glands up here? Oh, last week when you were stressed out about your exams and your grades, this little gland kicked out cortisol. And last week was rough. I had to do grades. I had to do everything. I also had several papers. So I was stressed out. Is it any wonder why I have a cough and a cold today? No, it is not a wonder. So suprarenal or your adrenal gland is above your kidneys. Sclero means hardening. So let's see, show answer. If my ureter is sclerotic, that means it's starting to harden up, because that's the next step after inflammation. Like you've heard cirrhosis of the liver or hardening of the liver. Well, cirrhosis is the chronic end part of a lot of liver inflammation. But then the cool thing about that is if you stop drinking, start leading a non-alcoholic life, your kidney will repair itself. It's amazing. I used to have these hyperechoic inflammatory spots because I spent pretty much half my life, drinking. A decent amount. I can't really say I'm an alcoholic. Also, I couldn't say I was normal, but I ran an ultrasound school 15 years ago, and we were testing the new machines. So when they ran over my liver, there's some ugly things. I got scanned a couple of years back for liver, and I quit drinking a couple of years ago. My liver is perfectly fine now. So it's all these years of doing the right thing, and now I gotta move myself away from being a meatitarian because you got to do the right thing. And I have a lot of friends. They're not full vegan, but they're really into that the more vegetable and fruit lifestyle. They have far less. They're the same age as me and has far less problems. Um, 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 like this morning, since I ate all that pork shoulder, it was rough waking up this morning. Right? Hypertension, much related to nephrology, because we know that because if I'm hypertensive, let's look back at this picture. See what's connected to your kidney? It's directly connected into your heart. It's right here. So if there's anything issues with your cardiovascular system, your kidney is going to get hit. And remember, we talked about that word. It's called sequelae. We know it's going to happen. Let's look at any other words. Hypertension, we already know. Nephrostomy tube. Let's talk about a nephrostomy. Stoma. We already know about a colostomy bag. Well, we can do a nephrostomy bag as well. For example, I don't want the urine to pass down here because I did some surgery down here or here because I want this thing to heal up. And urine doesn't need to be flowing through there. Even though urine is relatively sterile or considered sterile water, but all the salts and other things that are in it might affect the wound healing. So we inform a percutaneous nephrostomy tube. Again, this looks like it might be a scary thing, but percutaneous, per means through, cutaneous means skin. So through the skin in your back, we put a tube and then fiber optics guided into your kidney, right? And then we have this nice coiled tube that'll block the renal pelvis right here. So when urine comes down, it'll go into this blue tube here and into the catheter bag. And it's really neat. We look at the bag, we can now measure urine output directly. That bag, better pay attention to it. Ptosis, prolapse, going down displacement, you know that. Yes, Rafi, right? Nephrophy. Nephrophy is what? I want to do a surgical suturing, because of course, if I go in there and I cut things, I got to put it back and I got to suture it in, and that could be part and parcel of a nephropexy or fixation of my kidney. So you could see here too, right? You could also do suturing of other things, right? If there's damage due to a stone, if it poked a hole in your ureter or your urinary bladder, we could perform a ureterography. That's a tongue twister right there. Or a cystography, which is this right here. And cyst means urinary bladder. Now, you could be saying, well, Dr. Garais, doesn't cyst also mean other things? Yes. A cyst is essentially a bag of pus with a whole bunch of dead white blood cells and bacteria. But in this context, when we used the root word cyst in this context, it means urinary bladder. Hernia, we talked about. Oh, cystocele and rectocele. Now, let's remember, cele means herniation. And herniation essentially means that things that are sticking out that shouldn't be sticking out. So you could see here, right? You have a cystocele. This is your cyst or your urinary bladder in this female patient. And you see how it's like sagging or prolapsing to the point where it's blocking the vaginal tube. Okay. And then we need to see things like that, especially if mommy had a lot of children. All of this starts to collapse. Okay. And you could have a rectocele. Now, rectocele can also do this, and you can see it's sometimes it could also be so bad, and it'll start pushing on the urinary bladder, and then you're going to have some incontinence issues. And you could also have rectal prolapse. You could also have vaginal prolapse, right? And that's called rectocele, of course. And if the vaginal tube, because you see here, there's all muscles here, keeping all of these tubes in place. But if you had here, right, this gets enlarged and small, enlarged, small. If you have baby, no baby, like, I don't know, 6, 7, 8 times, right? It's going to mess with these muscles, and it's going to be, these muscles will start to, won't have the capability to keep these tubes in place. So you could have a colpocele, that's COLPOCELE. The vaginal canal could actually prolapse. So when mommy coughs, right, boop, this will come down, and that's not a good thing. Now you're out, now your internal organs are now out, external, and once that happens, it has a predisposition for infection. Rectocele as well, right? Mommy coughs or strains too hard, this tube will now then do what? This is part of your pelvic floor. This is your anal sphincter right here. This tube will then start pushing outward here. And that is not a good thing. None of it. Here's a cystoscope. We could, this is our male patient. Sedated, of course. Imagine we didn't sedate you. Woo. That'd be a venture, right? Which, by the way, when they take for UTI, oh man, I hate having to do this when my patient has a suspected UTI or suspected urethral stenosis. There's this wire tube that I have to put in here, and that's not with there's no anesthesia for that. And the glans penis right here is one of the most sensitive spots. So sticking that wire loop in when I had patients with suspected chronic or even acute UTI, when I want to do a scrape, wow. The only time I saw a man have to hold on to stirrups. And that is one thing to do. That's why always pay attention to female patients always pay attention to stuff and always go to the doctor, but get to your male patients. If even the littlest thing starts bothering you, go check it out. It could mean nothing, but it could also mean everything. How many times in routine, just looking around, I've caught cancers. I've caught some serious stuff. Radiography, that's another word for x-ray. You can do x-rays of all this other stuff. Let's see. Dynia, pain. Urethrodynia means pain in my my urethra, urethral. But really, how does your patient know it's your urethra it's causing the pain? But when your patient typically says stuff like, I have dysuria, right? It hurts when I pee. Let me write that word down. Dysuria. Doc, it hurts when I pee, or it burns, or oh man, like I feel like what's another thing? When the patient complains of, do you ever not you had to really go to the bathroom, but you held it because you had to be at the DMV or heaven knows whatever reason, right? And then when you pee, you get that cramping. It gets really, really painful. It goes, well, that is the same kind of pain. So that's urethrodynia, also known as urethral. But typically we write down the words dysuria. To talk about painful urination. Tumor, no. Let's bring this back down a little. Oh, this is your nephron. This is the microscopic. There's like 200 million of these in the outer rim of your kidney, called your cortex. But this thing right here, this tuft or this bundle of capillaries, this is called your glomerulus. That is the thing that gets infected when you have glomerulonephritis. Oligo, we already went over. Glomerulo, we already went over. Pyelo. Now, don't get pyelo confused with pyo. Pyelo means renal pelvis. Pyo means pus. Okay? That's a nice, hey, maybe I should put that on an exam. Here's urinalysis, the chemical portion of the show. This is called a dipstick. This is for fast, in lab, at bedside. I want to do real quick. But typically, if I do this, especially if I'm in a hospital setting, I'll send it out for a real urinalysis. The full urinalysis, that you sent to the lab. Now, those stones, remember lithiasis, also known as calculi? You see what happens? And this happened to my wife a couple weeks ago. This thing gets caught up here. Then you have backflow of urine, and then it causes hydronephrosis. That's bad news because this gets all backed up. Will there be good blood flow in this area? Nope. And then you could have also a complicating problem of infection. So when you have the stone, the next thing we're looking at is hydronephrosis. Because again, it is a sequelae. It's the sequel. And we all know about sequels. They are far worse than the original. Well, typically. Polyuria, we already talked about that. Polycystic kidney disease, right? Poly meaning many, cysts, right? Little bags of pus. That means this infection is rampant. Okay, that's never a good situation. Let's now look at some abbreviations. You have ARF and CRF. ARF is acute renal failure. That means it happened when? Right now. So let's say, for example, my patient got into a wicked motorcycle accident and then one of his kidneys got ripped out. That's acute renal failure. What's CRF? That's chronic renal failure. That's what happens over a chronic, ick pertaining to time, over a long period of time. BNO, they don't use that too much, but BPH, they use that a lot. Benign prostatic hyperplasia. Your prostate gland could, in the male patient, could be hyperplastic. Now, they call it benign because it isn't cancer or not cancer yet. So that's hypertrophy, and it's going to cause erectile dysfunction, sexual dysfunction. You're going to have dysuria. There's going to be a whole bunch of things. BUN, blood urea nitrogen. Remember we talked about azotemia? If I told you the BUN is increased or abnormally increased, guess what? You got azotemia. CNS, culture and sensitivity. When you have an infection anywhere, what do? I have to send a sample to the lab to see what kind of infection, that's the culture, and what kind of antibiotics or drugs can kill it. And that's the sensitivity portion of the show. So a CNS, it looks like a beautiful both A and B question. Cath, that's typically slang for catheter, sticking a tube down somewhere. CT, we already know. Cystoscopy, we already know. Scope. Now, this is slang. When we see cysto, nephro, we just cut it off, but we don't really use that. ESRD, very common. End-stage renal disease. That means we can do nothing for you anymore. We can't really cure you anymore. It's end stage. You're already at the last part of it. If you have ESRD, we're probably going to take that kidney out. Or just leave it in like my father and just do dialysis. And that's the beginning to the end. That's one of the several nails in the coffin for renal patients. ESWL, we already know. EU, we don't really use. But a urography, what am I doing? I want to graph or record the urine, and I could do it voiding or excretory. GFR is your glomerular filtration rate. We know that the glomerulus filters my urine, and I can measure that in my blood and in my urine. So the GFR can tell me the the functional status of my kidney. And if it's decreased, that's bad. You're going to see oliguria. You're going to see anuria. Hemodialysis, I don't know if they call it HD. Never seen it. HD to me means high def, means TV. IVP and IVU, intravenous pyelogram, also known as intravenous urogram. So let's look at that. Let's look at IVP in real life. So we did IVP on our patient. You see this wonderful, all the funnels, and then our renal pelvis, and then it goes into our bladder here, right? That's intravenous pyelography. So what did we do? I put this dye into your blood, hence the term intravenous, within your vein. And then I take a KUB, which is a kidney, ureter, bladder picture. And then we take it over time and we see things. And you look at here, nothing here, right? So this, my patient has, so the left side, see the marker? This is L. So this is the left side. So the left side of my patient, there's no kidney function. And you can even see, yeah, this looks a little bit of stricture here, but that's all right. Let's look at something here. Look at here. You have an actual stone. This is a hyper, you see this little, I was about to say hyperechoic, but it's not hyperechoic. Because it's not an echo. This is a KUB. And you can see how it's all backing up. This one, a little bit of stricture, but you can see, ooh, look, the right kidney's working fine. It's flowing, but the left kidney, look at that. It's all, it has already signs and symptoms of hydronephrosis. And how do I know? Because this is normal. This is what it should look like, but it's all puffy, right? So that's what IVP, IVU, and KUB can do for you. Peritoneal dialysis, polycystic kidney disease, that's good. PSA is prostatic specific antigen. When you have BPH, your PSA should be elevated. Okay. Retrograde pyrography, we're looking at the kidney from the level of, we're putting a tube and going up the urinary tract backwards. TURP, which is transurethral resection of the prostate. There's a picture of it, and we're going to get to it. But what are we doing? I am resecting back the prostate gland. And remember, prostate gland is only in your male patient, and I'm doing it through his urethra. Trans means across, right? So remember that picture? This is a better picture. Remember this one? I'm going right through the urethra, and I'm going to go, and let's say this is equipped with, what the hell is that? What the? Now we're giving alerts for vaccine. Give me a break. All righty. Let's go back to our ultrasound, US, urinalysis, UA or U/A, either one. I've seen both. UTI is a urinary tract infection, of course. Who will deal with it? Department of Urology. VCUG or voiding cystourethrogram, and it's the same thing as this IVB IVU, right? We make you urinate, and as you're urinating, we take a picture of it, gram, and we could see bladder and your urethral problems a little bit clearer. Azoturia, azotemia, we already went through that. Diuresis, ESRD, enuresis is involuntary discharge of urine, okay? Now, if your patient's greater than 5 years old, right, and they start wetting themselves, there's a multitude of reasons. It could be physical, and it could be also psychological. I had a friend of mine in high school kept on wetting himself, and it was so funny because they brought him to the psychologist, and he's screaming up and down like, I'm not on drugs. I just I just can't control it. So can someone please bring me to the doctor? And it was funny, after 2 visits with the school psychologist, they finally got him to the doctor. Guess what? He had he had a bladder infection that messed with his the urethral meatus, which was messing with the sphincter that was opening and closing his urine. And the whole entire time he's like, I'm not crazy. I don't wet the bed because mommy and daddy don't love me. I just remember him arguing all the time. And we just told him just to wear his Pampers and shut up. Isn't that what friends do? Right? You know, you just give bad advice. Hypospadias. In the male patient, the urethra should be on the top of the glans penis. And when it's in the undersurface, we have to do a little repair there. It's no big deal. It's just that when you notice the baby's peeing sideways, you gotta address that. The interstitial nephritis. Nephritis means inflammation, infection. Wilms tumor, that's a neoplasm, new growth. That means it is a cancer. So Wilms tumor is a carcinoma, and it's malignant, and it's no bueno, also known as a nephroblastoma. Patient I had was it was around 6.5 years of age. BUN creatinine. It's a way to also measure. It's another test that also deals with the what do you call it? It also deals with how well is your kidney function. So BUN, creatinine clearance, GFR. You put all those things together, we get a good picture of how well or how poorly my kidney is working or not working. We already talked about this. Here's an ultrasound, right? Uses sound waves. We talked about that. Here's a catheter. See how we go there, and it's indwelling. And then we can irrigate it out because this is definitely a point source of infection. And also you also have inflation of the bladder here to keep it in place. Here's the dialysis, the 2 types of dialysis. The one with the Fresenius machine is hemodialysis, right? It goes, and remember, it only does filtration. And this will drain your patient emotionally, physically. They get very, very cold, get very, very weak because I'm taking your blood out of you, and your blood is the main thing that is transporting all the fuel around in your body, but it has to be cleaned because we have to get rid of the nitrogenous wastes. Another way to get rid of nitrogenous waste is peritoneal dialysis. Now, this may look like it's from the dark ages, but it works. This was actually my first assignment when I was in the Kidney Institute as a first-year resident. This is what we do. You put this on a stand, and it has this stuff called dialysate. And this dialysate is clear. It's like a clear yellow. Then you let it drain, and it goes inside a port here that goes into your peritoneal cavity, your peritoneum, or the covering of all your intestines. Now, once your patient fills up, this all empties out and fills up, then we have the patient lie on their side, and you slosh them around. You move them from side to side and massage their belly a little bit. And then you have the patient lie on their side. And then you put the dialysate like on a box on the floor. And then all the stuff that got washed out here will now go into the dialysate. And you, pun intended, wash, rinse, and repeat like 6, 7, 8 times. Takes hours. And it has to be done in a sterile room because this port here is, and of course you have your immunocompromised patient. This port here is a major point source of infection. And you keep on doing it until this dialysis is clear. So you're gonna have these bottles, like there's gonna be like bottle one's gonna be really cloudy, two cloudy, three cloudy, four it's starting to clear up, five is starting to clear up. By bottle six or seven or so, it should clear up. Man, I had patients going through like 13 bottles. Just amazing. And you can't do anything. You have to be in that sterile environment. I have to be gloved up, bootied up. I also booty my meaning not that booty, the boots on your feet, and you have to have your surgical cap, and it's got to be in a sterile environment because again, point source for an infection here in the stoma, and also your patient is definitely immunocompromised. Ureteral stent, we already saw that. And a stent, oh no, we didn't really see that. Saw something similar. So what's a stent? Let's say there's a blockage here and we can't really repair it or it's really messed up. So we put a tube here and to bypass that blockage, and the tube goes out here, okay? And that's one way we could do it. Antibiotics, of course, deal with only bacteria. Antidiuretic, that's a pill that makes you stop urinating if you're urinating too much, or antidiuretic hormone. Its function is to stop you from urinating. Antispasmodics, we talked about, well, I didn't talk about that yet, but in anatomy and physiology, this tube here and this bladder, they have muscles covering it. So you can have spasms, right? And you can't really control it because they're all smooth muscles. So you could take an antispasmodic, and that's the first thing we do. If you have a stone, we relax all of this stuff up because that's what's also causing the pain when everything's all, squeezing, and then you got a stone in there, and then you see stars. Well, more than stars. Like I said, my wife is multi-gravid. She's lived through, and she never had any anesthesia. So she lived through several live births, and she said it hurt. The stones, passing a stone hurt just as much, and it lasts days. Oh, and my wife's like me; she doesn't like narcotics, so she didn't take any of her hardcore narcotics. She just lived through it. Diuretics, water pill, potassium supplements. Now, I have to replace stuff that you lose. Remember, I said the diuretics it tricks your your body into throwing out salts. Well, potassium is one of those salts, and if you lose enough potassium, you might have heart problems. Okay, especially if you're sensitive to potassium. Okay, I tried to get through that as quick as I could because I goes, what is our assignment for a discussion this week? Well, you have this case here and you have that case here. You also have cases at the end of your, what do you call that? Your other chapters, respiratory and cardiovascular. So you could do the same thing. So when we look at this, let's look at Mr. Jenkins here. Happy guy. 65-year-old male, symptoms of dysuria and urinary frequency. So could I have a question asking, goes, what is my patient's chief complaint? Right? And you have to know what dysuria means and urinary frequency means. So is it A, sexual dysfunction? B, it hurts when I pee? C, there's blood when I pee? Or D, I think my kidney fell out again. So that's what your final exam is going to start looking like. You're going to look at a case and it's going to ask you questions about the case, right? I could also ask you about it goes what in his what in his past medical history that he needed to remove a piece of his colon. So you know that remove a piece of your colon or your large intestine is called a colectomy. And why did we do it? Because he had colon cancer. It goes according to Dr. Moriarty, right? Again, you got to know who the people in your neighborhood. Dr. Moriarty, is he internal medicine, cardiology, nephrology, or gynecology? And of course, he had a consultation where they had to put a catheter in him for pre-op. For what? We are in the chapter of nephrology. So Dr. Moriarty has to be nephrologist, right? Let's look. Negative for transurethral resection of the prostate. So I could ask, did he have a TERP? Yes, no, maybe. Did he have any STDs? Patient claims none. No VD, no venereal disease. Which of the following were part of his PMH or past medical history? A, hemorrhoids. B, bilateral inguinal repair. C, high cholesterol. D, all of the above. Does my patient have any issues with his eyes? Yes, he had retinal surgery. Your retina is where? In your eye. When we did the inguinal hernial repair, did we do it on the left, right, both, or neither? It's bilateral. We did it on both. So you can see now how this case has so many questions. So what am I going to do in an exam? I copy and paste this case, and then you have questions that follow the case, typically 4 or 5 questions. Hint, hint, doesn't it now look like your NCLEX? Hint, hint, if you train for your NCLEX now, even before you get into nursing, how are you going to be when you actually have to take it? Again, it all goes back to training. I'm never one. I remember another doctor asked me, so Dr. Garais, you must have a high IQ. And I go, what made you think that? Oh, because, you know stuff and you do stuff. No, because I pay attention. Which, by the way, any of you think that you're not smart enough? I think my IQ is 98, which is super, super normal. And how do I know? In second grade, they found out my sister is a genius. She has 146, 147. My mother also, as well, is at genius level. Because back in the day, in the 50s and 60s, you can't go to medical school. Not only have to pass all the exams, you have a psychological test and an IQ test. If you don't pass any of them, you can't get into medical school. Nowadays, we don't care. You take your MCAT, you could be a complete psychopath and you can get into a medical school. But back in her time, so that's why my mother knows she has an extremely high IQ. But I have a normal IQ, but I have more degrees than my mother and my sister. I also have, so I've also done all these other things. So my thing is always about training. If you train, if you go hard all day, every day, 7 days a week, yeah, you get some rest when you can. You know, we're not supermen and women, but if you train consistently, the world's your oyster. You can do a ton of stuff. I've had new students complain to me, why didn't you put me in a math class? I told you when you interviewed me, I'm not good at math. And I told them, get good at math before you get into nursing and fix that problem before you get into nursing, which, by the way, not only pathology is a high failure rate class, you know what's another high failure rate class in nursing? Is pharmacology too. And why? What do you do all day in there? You do medication calculations and confirmations. If you don't know how to do that, how much trouble are you going to be in? You're going to be in a lot of trouble. And actually, that's a lot of errors in nursing, because your job as future nurses, well, most of you are future nurses, your job is to make sure my calculations are correct. All right. And even if I'm wrong, if you didn't catch it, woo, your supervisor is going to have a field day with you, and they're going to do stuff to you. Like I remember in medical school, I missed one calculation on meds. They made me do what they call a chart review. You look at every medication on every patient and redo the math on all of them. At the time, there was 37 patients in the ward. It took me I remember I got caught on a Friday. Saturday, I had duty. So right after duty, 4 p.m. on a Saturday, it took me until the next day to confirm everything. And then I learned my lesson that day. Watch your meds, watch your calculations, check everything twice, 3 times if you do, because remember, because that's our job. With no disrespect to any other field like business, if you mess up your calculations, then you mess it up, you go back, you write another plan, and you make up for the lost money. But here, when we hurt or kill people, you can't make up for that loss, especially the loss and trust in your patient. That's really hard. Now, if you look at this, the textbook even gives you all the, must-know medical terminology. It also gives you, hey, what prompted the consultation with the urologist? It even tells you Dr. Moriarty is a urologist. So you can actually take these questions. Oh, what abnormality did the urology discover? These are classic questions that get asked and answered in the ward. That's why hopefully we're gonna revamp this course, but that's why I teach this course this way from week 5 on, because this is the real thing that you should be studying, right? Of course you study the words, but no one ever is gonna ask you, honestly, like, oh, cardiology, what's the suffix? No, they asked you, hey, he goes, that EKG report, who did you send it to? He goes, oh, I sent it to cardiology. And EKG, electrocardiogram, he goes, did you talk to the tech? Did you talk to, and if you didn't know how to communicate, then that information, that vital information will get lost. Where was the patient's hernia? Was it left, right? I just asked those questions like off the top of my head, but you see how it kind of helped you a little bit? Here's a typical progress notes. And you see it has all the parts: chief complaint, past history, impression is the diagnosis, and the plan is the management. I could even ask you. It goes, we gave her Cipro, right? Which is an antibiotic. So it goes, her cystitis, was that bacterial, viral, or fungal in origin? Now, do you see how it's going to take, you need to take a little bit of time to figure that out? First of all, if you know anything about ciprofloxacin, it's an antibiotic. And you know antibiotics only deal with bacterial. So her cystitis was bacterial. It was acute and temporary in origin, but is most likely bacterial because the good doctor here, Dr. Josephson, I can't read apparently, gave her Cipro. Okay, and also, hello, management is incomplete. After the 7 days, come back in for reevaluation. That's not only how we make our money, it's also, you got to check, did the antibiotics work? Because if it didn't, I got to give her a new set, right? But a lot of doctors don't follow that, and they leave you alone, especially my dentist. My dentist never follows up to me. I only go see her every 10 years when a whole ton of my teeth start falling out. Now, remember what I mentioned before? These ones that look real familiar? Watch out for this cholelithiasis, with the gallbladder stuff. This looks like a beautiful gallbladder. See, look, right here. So that concludes this show, and also on how you are supposed to do your discussion 5, and of course discussion 6, which is due next week. And again, since you had exams and stuff like that, I'll give you until closing of business to deal with what you have to deal with today with no issues. So it's at this time, this part of the show, I will stop the recording.